Thank you for allowing me to wave on today to this important hearing, Chairman Griffith, and thanks to our panel for appearing today to discuss what is a very complex and important issue to many health systems and providers within my home state of Pennsylvania. The 340B drug pricing program was created in 1992 and aimed at enabling certain healthcare providers, known as covered entities, to stretch scarce federal resources to reach more eligible patients or provide more comprehensive services. Between 2000 and 2020, the number of covered sites participating in the program grew from over 8,000 to 50,000. During the same period, discounted purchases in the program grew from $4 billion to over $38 billion today. The original intent and goals of this program are critically important to protect patient access to care, but we cannot turn away from the staggering growth of this program and the impact that this is having on other segments of healthcare delivery system. I want to also be clear that we must ensure that any reform in this space cannot come at the expense of patient access to medications. Dr. DiGiorgio, the 340B program has grown massively since its enactment, what I just elicited, growing almost 130% in the last 5 years alone, and is second only to Medicare Part D. This growth has created misaligned incentives across the entire healthcare system, leading to further consolidation that drives up prices for every patient. In your opinion, would requiring covered entities to spend 340B savings directly on patients curb these abuses?
I think it would have some effect. I think there's going to be plenty of room for creative accounting around that. Again, as I said earlier, hospital prices are not very transparent to begin with, and so simply requiring hospitals to say that, again, if an inpatient MRI is $18,000 when it's really $600 down the street, does that really mean that the hospital is spending this money on inpatient services? There was a good article by Seah Nikpe in 2020 showing that 340B hospitals, in fact, reduced their charity care offerings when they joined the 340B program. And they have charity care offerings, but they offset that by reducing services in other areas. So I think there's a lot of ways that hospitals will get around that reporting requirement. I
don't like the concept of any creative charges or financing. I think transparency is important to all of us. One of the things I think is really, one of the things that's really driving the growth of the program and a lot of conflict over the future of the program amongst the stakeholders is the lack of a definition of a 340B patient. How would you recommend Congress define what a 340B patient is, Dr. DiGiorgio?
I think that they should have established ongoing care with that entity. And that can be something as simple as, a cancer patient that sees their oncologist and has an established oncology plan and continues to have regular check-ins via telehealth, via phone call, et cetera. But as long as they have an established ongoing care plan with that facility, they can be a patient and not just.
I think that certainly could be one of the requirements for identification of a 340B patient. Mr. Perry, there's currently no requirement that 340B covered entities pass savings along to patients. Right now, most patients receive 0% discount on prescription medication purchased under a 340B program, while according to HRSA, hospitals receive discounts of up to 50%. Why are discounts not passed on to the underserved and the vulnerable patients that this program was intended to serve?
Respectfully, Congressman, I disagree with your proposition that hospitals do not pass along those savings. As I described in my earlier description, we provide a discount program for patients who cannot afford their medications. It is only if you're under 400% of the poverty limit, any prescription that you fill from one of our covered entities costs you only $5. And we spend $3.5 million a year making sure that our patients get their medications. That's a huge part of our program. So I just believe.
Is this for all patients or just for 340B defined patients?
It's for all. It's for any patient who needs their medication.
But if a patient has a subsequent insurance and the insurance company is building their additional costs that are recouped by the hospital, where do those funds, where do those resources?
I'm sorry, could you repeat your question? Sorry.
Yes, if a patient has an other insurance that is not an underserved patient, but a 340B program is utilized, Where are those resources? Because they are not refunded to the
Right, so that is where the funding for 340B actually it comes through. It's through either insurance, patients who have insurance like commercial insurance or Medicare, and if we were a 340B hospital or if we weren't a 340B hospital, those payers would be paying the exact same amount. So it basically gives covered entities the ability to use those savings to be able to reinvest back into our entire care system.
My time has expired. I will submit the rest of my questions for further review. Thank you, Mr. Chairman, and I yield back.